Hey, good afternoon, everybody. Thank you for attending our TIA Recognition Referral webinar hosted by us as the Great Manchester Neuro Rehab and Stroke Delivery Team. My name is Chris Ashton. I'm one of the network facilitators and a paramedic by background. I'll be hosting today's live webinar. I'll also be joined by three of our team in Dr. Krish, our network clinical director, and a stroke consultant from Stepping Hill Hashu team. Alongside Krish will be Jung Kim, our network acute clinical lead, and also a stroke consultant at Salford Royal Hashu. And finally, supporting me to facilitate all the Q&A and select our questions for our presenters will be Asim Mishra, our network and ICS CVD prevention lead. He also works in primary care setting and is a senior population health follow-up within Rochdale. So thank you to the team for taking their time out of their busy days. And to start with some quick housekeeping, we would encourage you to enter your questions for the presenters in the chat or in the Q&A box, apologies. And Asim will kindly select these for our presenters. Our presenters may have the opportunity to answer some in the chat too, possibly, but we'll touch on some of these after each presentation. Now, in terms of today, the recording will be available. We encourage you, if using Twitter, or should I say the X platform, our Twitter handle is on the screen and please make use of that. Now, we do have a network YouTube channel with many other webinars, and you'll also be sent a link of today's following the editing of the video and upload onto the channel. And we really ask you to evaluate today's webinar. This can be done through our QR code, as you can see on the screen. If you need to hold your camera up to the screen and take a picture so you've got a link to that, feel free now, but I'll also share that again at the end. So do not worry if you missed that opportunity. Now, the webinar today also has CPD points accredited to it. And the best contact for any issues will be Karen Smith within our team, as per her email on the screen. So in terms of the learning for today, firstly, thanks for your engaged responses prior to the webinar, and we hope some of the key learning points will be addressed by our speakers who look to focus on the clinical features of TIA with some clear explanation of the common mimic presentations we see. This hopefully will support the ease in understanding when a referral is clinically indicated or not. Our final key learning points will then look at to address some of the challenging post-event advice that you or we may give to our patients, such as advice on driving and follow-ups, etc., and the use of medication around secondary prevention. So without further ado, I'm going to invite Krish to share his slides for our first presentation around the clinical presentations of TIA. So thank you very much, Krish.
Thank you, Chris. Welcome all. And I recognize it's a busy morning and probably you are, for those who managed to join in between your morning and afternoon surgery, welcome again. I know you've taken the time to attend this. So I'm just going to share my slides quickly. Okay, so without, I'll just move on to the next slides. I don't have any disclosures to make today. This is purely organized by the Greater Manchester Network, and there's no conflict of interest or any disclosure to make. My two topics are essentially recognizing the key clinical features of TIAs and how do we go about differentiating those from the common mimics. And I'm hoping to cover this too within the next 30 minutes. Most of my talk will be based around the recognizing and diagnosing TIA, but I just felt it is important that we just briefly spend some time on the definition, incidence, and pathophysiology. Risk factors I'm not going to dwell on too much because I know you are well versed with most of the risk factors and how to approach the same. So the definition, this was the previous definition we had, which was a time-based or temporal-based. It was an arbitrary time frame of 24 hours and essentially a sudden onset of neurological deficit, focal in nature, presumed to be vascular origin, and confined to an area of a brain or eye perfused by a specific artery. This is the World Health Organization definition and has been in place for many years until 2002, when this was debated at length. And the reason for that is the definition in itself, a time-based definition, gave the impression that TIA symptoms are benign, which we know it isn't. There is a higher risk of subsequent cerebrovascular events in the first 7 days or 90 days, in fact, and most of which is front-loaded. And also, there's no pathophysiology in the diagnostic definition. There's no end organ damage definition. Is purely a time-based based on the resolution of symptoms or otherwise. And we know that the symptom resolution does not accurately predict the absence of an ischemic brain injury. Now, when they looked at when the diagnostic imaging modalities has become more frequent, including particularly MR imaging, there is enough and more data that has come through the years that illustrates the point that if patients were to have TIA symptoms lasting more than an hour, then very few of them will have complete resolution of symptoms at 24 hours. And the same applies if you were to image, the earlier the better, image these patients, particularly patients who have prolonged symptoms more than an hour. Many of them had DWI, ischemic abnormalities, which went on to become permanent infarcts in a subset of those populations. So I think there was a revised definition was very much needed. And in 2002, it was explored, and this is the current definition in UK. But in Europe, they don't even have the less than 24 hours. They essentially define neurological dysfunction caused by a focal brain, spinal cord, or retinal ischemia without evidence of acute infarction. And they don't define the 24 hours. But in UK, we've included that within the definition, but have incorporated without evidence of acute infarction to define TIA, and with evidence of acute infarction will be stroke if the symptoms last more than 24 hours. Now, just quickly, I think that's a very important point at the bottom, that most people will have the complete resolution symptoms within an hour. And as I said, if the symptoms last more than an hour, certainly beyond 2 hours and 3 hours, if you probe them enough, you can tease out subtle persisting neurology, and that is a point to remember. The incidence, I think data around it is a bit sketchy, but the quoted incidence in the NICE document is 50 per 100,000 population. So if I were to think about Stockport, which has got a 250,000 population, we are talking about 150 TIAs per year. We see around 120 referrals per month, just to give you a scale of the referrals and what is back, but this might be an underestimate. Pathophysiology briefly, and I think the fundamental pathophysiology is the decrease in the blood flow. It can be due to a number of reasons, either embolism or in situ occlusion due to atherosclerosis or of the small perforating arteries. Nevertheless, the reason why the symptoms resolve is because of either spontaneous lysis or the occlusion moves on to a distal smaller blood vessel without much of impact, and the collateral circulation taking on some and restoring the circulation of the ischemic area, and hence resolution of symptoms. Risk factors, I'm not going to dwell much on it other than just bear in mind the hyperviscosity and the giant cell arteritis and malignancy, but the rest of the things you will know. Now, coming to the main topic, recognizing TIA. It's not easy, and I think we know from various studies that the concordance between stroke clinicians and neurologists and generalist and stroke clinicians, there has always been some variance, and even between neurologists as well. But the degree of certainty improves as we with the neurologist being the highest and the rest of the stroke clinicians. But there are certainly some pointers which we can help to recognize and think about whether it's more likely to be a TIA or a mimic. The main question when you're approaching this is the fundamental pathophysiology of the TIA, which is a blockage or is it a vascular event? And to answer the question from a history, these 4 points are very, very important. And I think you should constantly refer back to these 4 points when you're talking to the patients in trying to tease out the symptoms. Focal, whether they are focal symptoms rather than non-focal, and I will come on to in a bit more detail around this. Whether they are negative, i.e. loss of specific function rather than positive symptoms, whether the onset is sudden or gradual, and whether the symptoms are maximal at the point of onset rather than gradually progressive. So these 4 points are extremely important, and you must incorporate that in your history and teasing out the symptoms from the patient. Focal, I think the focal neurological symptoms essentially can be motor, language, sensory, visual, or vestibular thing. I just want to make a point there here. Isolated diplopia, vertigos, where TI could happen, but in isolation is very, very rare for that to be diagnosed at TI. That's not the first thing that will come to mind when patient presents with isolated vertigo and or diplopia. Of course, these symptoms can be associated with other symptoms, in which case the diagnosis becomes more feasible. Making a diagnosis of TI for this non-focal neurological symptoms, one need to be very careful unless they are associated with some focal neurological symptoms. And that includes generalized weakness, blackouts, incontinence, lightheadedness or non-rotatory dizziness, amnesia of the event, confusion, except confusion can be manifested as language deficits, but on sensitive probing, you might be able to tease that out, whether it is a language issue or true confusion. So focal versus non-focal, that's the first question when we are exploring the history, and particularly when you see non-focal neurological symptoms as the sole presenting symptoms, your threshold of diagnosing TIA, goes down. The next is positive versus negative symptoms. Negative symptoms are more associated with TIA or stroke. When I say negative symptoms, loss of power, loss of sensation, vision, balance, speech, or swallow. Whereas positive symptoms are pins and needles, jerking movements, flashing visual symptoms, tingling. They are called positive symptoms. If somebody is presenting with just positive symptoms, the likelihood of this being a TIA is unlikely. However, if positive symptoms are associated with negative symptoms, then you need to think about TIA as well. So, but positive symptoms in isolation, the likelihood of TIA is so. Focal versus non-focal, positive versus negative, and the third point is about sudden and maximal at onset. A vascular event, you would expect the symptom tend to be of sudden onset or abrupt, and whatever symptoms they have, they tend to be maximal at the outset. What I mean by that is if somebody develops a weakness on the right side, it was a grip reduction. That grip reduction does not progress. Whatever grip reduction we started off with will be the same, more or less, throughout the duration of the TIA, and usually it's followed by a gradual offset. So whatever neurological symptoms they develop, they tend to be maximal. It's not progressive worsening neurology. And it has got a very good predictor for the final diagnosis of TIA. Now, the duration of symptoms, contrary to what one would think, doesn't have much of a statistical significance between TIs and mimics. So don't give too much credence to the duration of it, whether it's 2 hours, 3 hours, like that, between a mimic and a TIA. But certainly, abrupt onset and maximal at the time of onset, and followed by a gradual offset, is relevant. So why is not that simple diagnosing or recognizing TA? As you can see from this picture, it is there, subtle. You can see the left facial droop and loss of lacerebral fold, and you might get all kind of minor neurology when you see patients, but it's putting that in perspective with the history. There's no gold standard test for TIA. An MR scan can be negative, and the diagnosis is mostly made based on the history and the history in detail. And I can't emphasize this enough in this point. And the diagnosis or the eventual final diagnosis rests heavily on the patient's account of the history and how we interpret that history. And it is useful to probe patients' description of symptoms, what they mean by that, as the symptoms mean different things to different people. And definitely probing, when they say numb, not take it for granted, it is numb as we know as a loss of sensation, but ask them to what do they mean by numbness? And the same applies for heavy, I feel dead or weak. And the chronology of symptoms is very important. What started first, and then what happened next, and what resolved, and then what we're left with, like that. You got to start with which started. Always start with the first question is, what is the first symptom you noticed? Then what happened? How soon after? Was it the same time? So that is relevant in going back to your answer to the question, whether it is abrupt onset and maximal at onset. And any associated symptoms, that is needless to say. Particularly, we are looking for other symptoms, whether there's any other than neurological symptoms, any other associated symptoms is important. Now, so the classical, so I just keep referring back to this when you're taking the history. Very important to go through these 4 parameters and teasing that down in the history. I recognize not all of it will fit neatly, but once you explored all the 4, your picture will form in your mind as to what that could it be. Now, the classical symptoms of TIA is, as I said, the loss of power, speech, sensation, vision. But don't forget about monocular visual loss, amaurosis. And usually these 4 symptoms, vertigo, diplopia, dysarthria, and ataxia, in isolation, one would think less of, it's not impossible, but one would think less of a TIA unless they are associated with other symptoms above. So I think in approaching or diagnosing a TIA, obviously there is one aspect of excluding or differentiating from mimics. But the first question is it a vascular event? And I just hopefully has went through that section. So the next title is the differentiating TIs from common mimics. So having understood the approach of some of the history in establishing whether it is a vascular event, the 4 points I referred to now, how do we go about differentiating the TIs from the common mimics? I thought we will go through some case histories just to, and these are case histories which has come through our referral pool over the years and recently in the last 2 months. So 40-year-old female on oral contraceptives, otherwise healthy, had sudden onset of some visual disturbance and then tingling and numbness in the right arm. The symptoms, she was not, when you probe the visual disturbance, all she could say was she was not able to see one on the right side of the field briefly, and it didn't last. It lasted for around 10 minutes, and then it improved, but never completely resolved. The symptoms of the tingling started in the hand and then to the shoulder and the face over a course of 5 minutes. And then she said it's followed by some heaviness in the arm. She didn't volunteer this information, but on probing, she said that there was some word finding difficulties, but lasted only for 5 minutes. And the whole symptoms resolved after 30 minutes, followed by a mild headache. There's no history of migraine. The diagnosis made was migraine. Now, the reasoning behind it is, I'll come to that, and we'll just go through, because this patient did not have the classical migrainous present, where the headache didn't precede the neurology. She had some motor symptoms by a description of some heaviness in the hand, and she had some language deficit. So it's not the classical migraine. She's presented with migraine with focal neurology. So it's well recognized, particularly I think we see this cohort of migraine in the clinic. So probably we are very much familiar in the TI clinics with this presentation, whereas I'm sure as GPs you would see the other side of the conventional classical migrainous presentations. Migraine can present with sensory, motor, and speech disturbances, and the common speech disturbance is usually dysphasia, and the symptoms develop gradually over 5 to 20 minutes. Often there is positive symptoms. They start off with positive symptoms, which could be, if you refer back to my previous slides in the earlier presentation, is either pins and needles, tingling, flashing lights, like that, those symptoms. And sometimes it can be followed later by negative symptoms, either numbness or weakness. Visual disturbance, as I said, is the most common. It can migrate across the visual field, and then followed by visual field deficits. This word is important, and we need to probe when we are seeing the marching nature of the symptoms. I start from the hand to the arm to the face over several minutes, and then they're sequential in nature, in the sense as one symptom, when the hand starts to resolve, the symptom starts in the arm, and then the face, like that. So with one resolving symptoms, the other one begins, rather than all simultaneously in TIAs, abrupt onset, maximal at onset. Headache can be minimal, unknown, and can be delayed for more than an hour after the end of the aura. And people can have all of these symptoms without headache, as in the case of acephalic migraine. Now, it is important to acknowledge that migraine can change in its pattern, and sometimes it can be triggers for that as well. So migraine can change in its pattern from non-neurological symptoms related migraine to focal neurological deficits. And it's not inappropriate to refer such patients, but once you have this migratory marching nature of the symptoms and sequential nature with some positive symptoms, then you know where what's the more likely diagnosis to be. I think this is straightforward, but just to illustrate the point of some of the referrals we receive in the GI clinic. This was a patient who collapsed after coming back from shopping with loss of consciousness, and came around within a minute or so from the eyewitness, from the husband. And all she could recall was some visual dimming before the episode. She's a possibility of hypertension, and she's on angiotensin II blockers. She had a similar episode a year back, but none in between, and has been otherwise well. And from the history, with the loss of consciousness, with a spontaneous recovery, with some associated pre-syncopal symptoms of visual dimming, this was labeled as a syncope. Now, I don't need to brief on us too much, because as GPs, you are very familiar with it. But the transient loss of consciousness is not a symptom of TIA. It can happen very rarely in transient vertebrovascular insufficiency, but as I said, it's extremely rare for the patient to present with that symptom alone. So if you have a loss of consciousness, TI is not the diagnosis that is foremost in your mind. And often you have to probe these pre-syncopal symptoms leading up to the actual event. Particularly, patient can describe hearing becoming muffled, or vision may darken, or dimming of vision, and they might describe it in different terminologies, but it's important to probe these. And the whole episode usually lasts less than a minute and rapid recovery. In older people, sometimes you do see some focal symptoms of jerky, and often you can get some non-focal symptoms of brief confusion after, but that is also very rare, but that tend to be people with cognitive or other. Of course, syncope is always a concern in patients with cardiac causes. The importance is more at-risk patient to exclude cardiac causes. So it is very important these patients are referred to the right specialty. This is a patient, 64-year-old, who described what each 6 to 8 attacks of pins and needles in the right arm and leg over a period of 6 weeks. It has been, she describes this as like water running up her leg, and the sensation starts in the foot and then goes up the whole up to the arm over a period of a minute. Each attack is more or less similar, lasting then less than 2 minutes with full resolution. Here the diagnosis is focal aware seizures, otherwise, we previously used to call it simple partial seizures. The patient is aware during the attacks, but the stereotypic nature, some sensory symptoms with a marching nature and pins and needles would point to the diagnosis. Now, seizures can present with, I think, generalized seizures or tonic-clonic is very easy to diagnose, but sometimes you may not have a good eyewitness account for that. So it's very important when patients present with any transient neurology to probe around the episode, whether there is an amnesia or loss of awareness of the event, because if they were present, they point very much towards an mimic, particularly seizures, rather than TIA. Often seizures on both, partial seizures as well as they will often have positive symptoms to start with. Often they describe as painful sensory symptoms, or sometimes focal limb jerking or automatic movements like lip smacking. We do see quite commonly in hospital settings, this is followed by negative symptoms, and they trigger the pre-hospital stroke pathway, and which is and then resolves over a day or so, which is Todd's paresis, or on the same day. The key bit here is, obviously you will ask for other symptoms, associated symptoms, tongue biting, incontinence, but that may not be the classical description. Often patient complains of significant muscle pains. You wouldn't expect that to TIA, or exhaustion after the episode to the extent they felt they need to sleep it off, or disorientation which lasted for another hour or so, but not language deficits. And often they describe headache follow the episode as well. But as I said before, amnesia or loss of awareness is key to the thing, and marching nature of the symptoms, particularly positive symptoms, is the clue here. Complete speech errors is very, very rare with TIA. Not seen one in my experience. And aimless staring, cessation of speech, mid while they're talking briefly, less than a minute, and then back to normal. Often they are also not here. The key bit is to ask the question, have you had any similar episodes? Maybe not this worse or similar, but intensity was more, or duration was more, but the nature of the symptoms were exactly the same. And when you have somebody saying, I had 5 TIAs in the last year or previous year, or 6 TIAs, the diagnosis usually it's not TIAs, and it is high time to revisit the diagnosis. So the stereotypic nature is the clue here, and the positive symptomatology and the marching nature of the symptoms, usually lasting and some associated other features which are non-specific, but on probing often they refer to that. This is a 42-year-old male who's healthy, mild anxiety. He had sudden onset of speech disturbance on waking up. He witnessed with a wife who noted him to be awake, alert, but completely mute, staring eyes straight ahead. Recovered after 30 minutes and complained of subjective weakness on the left side with intact mobility. He does not appear worried about what has happened, and as you can see, the clue completely mute is very, very unusual to have a mute. Essentially, mute means you have both expressive and receptive, which is rare in the absence of any motor symptoms, and it doesn't fit in with what you would expect with any focal thing. And this is common. This is not a diagnosis to be made in primary care or in GP, because this is often a diagnosis by exclusion of other conditions and rarities before we come to the conclusion of it. But we do see this quite commonly in the TIA clinic, and it's not an uncommon mimic we see in the TIA clinic. So I felt I should include this. Yeah, so it's usually symptoms on waking up. We tend to have younger patients. Often they have no vascular risk factors. In the event, if you were to witness them during the episode, they often have a collapsing weakness. If you ask them to put the arm forward, they just completely collapse, and there is often inconsistency between symptoms and what you find on neurological examination, or when you observe them, you see there is variable neurology. Often they're indifferent to their symptom. They don't seem bothered by the actual neurology they're having. And it's not the same as malingering. And I think that was in the questions that was asked about who was assigned. As I said, who was assigned is only relevant if you're seeing the patient at the point they have a neurology. Otherwise, there's no point doing it. And TIA patients often, by the time they come to your clinic, the symptoms are resolved. They don't have any ongoing symptoms. And nevertheless, I put up the who assigned because it was in the questions asked post by the group. As you can see, let us, a patient A, you make them lie on the bed, and essentially he's complaining of right-sided weakness. And you ask the patient, you put your hands underneath the heel of the right leg, and you ask them to push down with the right heel. And you will see actually no effect, no power, nothing, no response at all. Keeping the hand there, you put your hand on the left leg in the thigh, and you ask them to lift the left leg up, and you will then see a downward movement on the side on the right leg where he was weak, and it extends, suggesting there is power. So essentially, who was saying it's positive, and again, it is fairly a good sign to as one of the tests to incorporate into your assessment when suspecting functional neurologic disorder, but only relevant if when you have the when you're seeing the patient at the time of the symptoms. The next patient is a 60-year-old male. Wife sought help because she thought he was confused. He was confused while out in the shopping center. When you talk to him, he makes perfect sense. There's no language deficits, but he keeps asking, why are we here, and why are we not going shopping? And that's the description from the wife, that he was repetitive in that questions. He can't recall events in the shopping center, but otherwise had a normal neurological examination, or he did not have any of the neurological symptoms from the wife's history. I think this is rare condition, transient glucose, but we do see them occasionally. It's quite dramatic, and often the patients get really worried about the amnesia side of things, and they do seek help. And so it's not an uncommon scenario to be faced with. In secondary care, we probably might be seeing less. Maybe in GP, you might be seeing more than we are. So what does it entail? Essentially, it presents as a sudden disorder of memory with no other neurological symptoms, and it can last for hours. You tend to get temporary antegrade amnesia, and it's essentially for a period of the day, they can't recall the events, what they did. After the attack, the memory is okay, but they keep asking the same questions of what happened for that period. I think it's fortunate the reassuring bit is when they followed up these patients, there is no increased risk of stroke, and the risk of recurrence is also low. So symptoms versus diagnostic possibility. Now, these are not absolute statements, but it is useful in your approach. Certainly, frequent or stereotype symptoms are not usually clear. Or you must almost always think about a mimic when somebody's having the same symptoms recurrently and frequently. Loss of consciousness or altered conscious level, very, very, very rare with TIA. Evolving or marching and spreading symptoms of neurology, again, you would think about mimics rather than TIA. Non-focal symptoms, in the absence of any other focal symptoms, again, you would not think about TIA. The first point about isolated, I referred to it before, is less likely, but it's not impossible. But the key here is if you were to probe in the history or seek out other neurological symptoms, often you'll find subtle other symptoms as well, which the patient was not voicing. So these are the common things we encounter in the TIA referrals, migraine being the highest, seizure, syncope, peripheral vestibular disturbance. I have not gone into it because some of the distinguishing features for that, it is more relevant when you have the actual symptom, particularly the Hinds test and the Hall-Pike test are more relevant when the patient actually have the vertigo or vestibular symptoms. Now, it's all great, and but as I said before, because the diagnosis is clinical, sometimes you may not have everything fitting in neatly with anything, and it is important to sometimes say we are uncertain as to what this could be, and that is absolutely okay, and we do that all the time with the patients, and there's no classification for that, and which regards to in the what we would call it, but often reasoning out with patient why we feel what it is, and keeping that under observation is not an unreasonable, particularly if you don't have the symptoms fitting neatly into one category or you're not too concerned about them. Now, there is an entity which we can use. It's a recognized entity. It's called transient neurological attack. I think that's a broad umbrella, transient neurological attack, and TIA comes under it, which is called focal TNA. There is another entity called non-focal TNA. This is where the most of the categories or some of the symptoms which doesn't fit in neatly with any other things comes under. And it is not unreasonable to label these transient non-focal symptoms as non-focal TNA, particularly when they lack a clear alternative diagnosis. I just put it out there, just if you're struggling for, rather than automatically labeling them as functional. So in summary, I just want to reiterate that history is the key here. And the history, don't forget, is never, it is best taken when the first time when you're seeing the patient or from the eyewitness. Focus on the chronology, what started first, how it progressed or not, and like that, and what resolved and what carried on and over how long. Any associated symptoms, particularly focusing on any non-focal symptoms or other features which I refer to in some of the common mimics. Yes, and while you're eliciting the histories, try to pose the question to yourself that 4 domains I talked about, whether the symptoms point to a vascular event or not. I think that's my presentation. I hope I have not overrun, Chris. I don't know how I am with time.
No, that's perfect, Chris. Thank you very much for a detailed presentation. And just on that, as we mentioned, we will offer the opportunity now. I'll invite Asim to come forward. I think there's a question in the Q&A, and I think there's one in the chat as well. So I'll let Asim promote them to you, Chris, and then I'll let you introduce John Gim, who'll come on and do the presentation. Thank you.
Thanks, Chris. That was really, I learned a lot in that talk, and I've never had it presented in that way before. I think you gave us some quite clear, actionable, practical approaches. The focal, non-focal, positive, negative, sudden and maximum at the beginning, gradual offset. I think that's really useful. I was just thinking, and I think the cases you picked were perfect in really hitting the nail on the head in that uncertainty, especially with the functional neurological disorder there. I was thinking with the positive and negative, is there a pattern of symptoms where even negative findings become quite worrying for vertebral or posterior TIA strokes? Because that's, I think, an anxiety we have in the back of our mind that with the negative type symptoms.
I think any negative symptoms, we should be worried, Asim, unless.
Oh, you're muted. You. Apology. Positive. So when you get, say, strange jerks or vague dizziness or disequilibrium or those kind of positive symptoms.
Yes, so the disequilibrium comes as non-focal symptoms. We don't call it positive, but the answer to your question is, if the positive symptoms predate the negative symptoms and have some of the chronology and the marching or sequential nature of it, I would not be too worried about it. But if they are simultaneous or the patient is unable to describe what started first on thing, any negative symptoms, you should be worried or trigger the referral. I think that's a safer approach. So I think the key is about whether the positive symptoms predated the negative symptoms. And if so, did it follow a pattern that you can relate to either migrainous or epileptiform of the two scenarios you described? If you can't, you refer.
Yeah, and I think that leads on to maybe more of a comment rather than a question, I think, Rao. Rao Guide was making. I think it's good that we talk about it. The question or comment was, it's worth noting how many of these patients were referred to you, felt it was not a TIA, and were sent home without any further investigation. But I think from what you've said, it's the history, and that's not necessarily a wrong thing to happen based on what we do in primary care and the role you have in secondary care.
So let me unpick.
Oh, you're muted again.
Let me quickly unpick that question into two strands. So the current false, the referral to positive diagnosis of TIA is roughly around 30% of the TIA. So 70% is not, 70 to 80%. Of the 70%, I would say 30% we do not do any further investigations or anything, just from, because as I go back to, it's often, if the history fits in with it, there's no point medicalizing an issue when it's not needed to be. So there's still a cohort, of the 70, another cohort that we go through investigation, and then we conclude with a bit more of thing. So yes, so it's
You're muted again.
okay.
There you go.
Yeah. So I don't know whether you got it all. I don't know where I got muted again. So
yeah, the last bit just muted at the end there.
I'm just saying, and also the level of seniority the patient is seen also matters in terms of the experience. So obviously that has a direct correlation to some of the diagnostic conclusions, at least on the initial assessment.
Amazing. And it was really interesting to see you have functional neurological disorder there. And it was interesting that people asked you or asked us about Hoover sign. But I'm just thought it might be useful to hear your thoughts about how useful that is in real life to exclude things from a primary care perspective. Like, it feels like a nice thing, but I'm uncertain as to whether we should use things like that.
I think often you'll start off with, as I said, a non-focal TNA or a transient neurological attack, and then adopt a wait and watch policy if it doesn't fit into anything. Any FND diagnosis has to be made through a neurologist. I think it's very clear in the guidance. You can't make a diagnosis of FND unless they've gone through a specialist workup and conclusion of the diagnosis. So even the patients we see in the stroke clinics, when we are not non-neurologists here, but Salford will have some neurologists within the TIA setup, we do suspect it, we know that is what it is, but we do refer to neurology for confirmation of the diagnosis. So answer to your question is, you may not want to medicalize maybe at the outset, and then you can use terminologies like I said. If you're not too much worried about the patient and you have a fair idea, you think it is probably related to anxiety or what, functional, you can document functional overlay, maybe some pointers towards it with other issues dominating the life or whatever. If you want to label it, you can use it as a non-focal or a transient neurological attack, not necessarily learning meds, a TIA or whatever. But diagnostic conclusion has to be specialist.
Yeah. Thanks, Krish. I think that is all of the questions that we had. I think there's a lot of other questions, but they're now about you. You did a really good job on the first step, and so now the questions are all about the next step.
I will leave it with Jay. Yeah, thank you.
Okay. So I think my key learning before we move on is that this is a tricky topic, which is why we put this webinar on. And you've heard it from Krish's mouth that, the referrals are expected, and being safe and managing uncertainty is important. And I think if we follow those key principles, that's first principles, vascular event, focal general, with the guidance that we have, then we'll probably be doing the right thing, or as much of a right thing we can.
Yep.
Okay. So my talk is, I will try not to talk about the diagnosis bit anymore, because Krish has done a beautiful job. And that's a tricky talk, because we're purely reliant on history, really. We can't really rely on anything when it comes to diagnosis of TIA, given that there's no remaining deficit in these patients. So thank you, Krish. So now I'll talk about what to do once you suspect a TIA. Starting from a GMTI referral pathway. So the current GMTI service provision is that in most units, 5-day TIA service is available, except for Salford, where I work, where 7-day service is in place. And the setting is variable across different units. It can be dedicated TIA clinic, or it can be a part of the neurovascular or stroke follow-up clinics. Unfortunately, the current waiting time, which hopefully should answer one of the questions, is variable between less than 24 hours and 12 weeks. So once you suspect a TIA, who would you refer, how, and where? So let's talk about who first. Who to refer. So if there's a single episode of suspected TIA, and again, I won't talk about the definition of suspected TIA anymore, it depends on whether the patient is on anticoagulation or has a known bleeding disorder. And then the second scenario is that what if there's more than one episode of suspected TIA within 7 days, which we call crescendo TIA, or whether there are any high risk features of TIAs. And the third scenario would be when there are ongoing symptoms. So a single TIA who's not on anticoagulation and who does not have a bleeding disorder should be given aspirin 300 immediately, unless there's a contraindication for aspirin. And they should immediately be referred to TIA services for urgent specialist assessment. And that obviously includes retinal TIA, also known as amaurosis fugax as well. And they can be directed to the Stroke Association website for additional support so that they can have some understanding to replace patient information leaflet as well. And safety netting is very important even when they are waiting for the TIA assessment in TIA clinic, because this is from GIRFT report, which is from a few years back, but Oxfast study suggests there are around 60K per year new TIA diagnosis in the UK, and 17% of these patients suffer from stroke within 3 months of having TIA. So it's safety netting is very, very important so that they can come to hospital as soon as possible once they recognize another onset of new neurological deficit. What if there's a single TIA, but the patient is on anticoagulation already for some indication, or has a known bleeding disorder? Then this is the majority of my slides are actually from the National Clinical Guidelines from 2023. So hemorrhage requires exclusion, and this is the wording from the guideline. An enhanced CT should be performed urgently. And this is one of the examples where the patient was found to have a convexal subarachnoid hemorrhage, even though the symptoms did not persist, symptoms were temporary, and the patient was on anticoagulation. Obviously, they having an increased risk of bleeding, and it would be difficult for you to initiate aspirin before ruling out hemorrhage. What if there's a crescendo TIA or other high-risk TIAs? It's not really written in the guidelines, and I think the practice may vary across different units. But at least in Salford, we do see crescendo TIA patients in A&E. They are seen by stroke team. We do accept referrals by GPs. I don't think it's written anywhere. So it's rather informal because we recognize it as a high-risk TIA. Other potential high-risk features can include, so this is from an American Stroke Association scientific statement, fluctuating neurological symptoms and signs, recurrent TIA within past month, so it may not be just within 7 days, even past month. And if the patient is known to have the ipsilateral carotid stenosis to the involved hemisphere, therefore that carotid stenosis has become symptomatic, If there's any suspected acute cardiac process or arrhythmia, or if there are other conditions warranting admission, you might have to consider sending these patients to A&E for urgent assessment rather than an assessment in the clinic, and to not use ABCD2, ABCD3, or ABCD3I, whatever the risk stratification tool is available. It's been advised not to use these tools anymore quite a few years back. What if there are ongoing symptoms? So somebody had a transient focal neurological deficit, but you're not sure if the patient's completely recovered or not. There may be some ongoing symptoms, but not very significant. This is not a TIA. So if there is any ongoing symptom, please do not consider this as TIA. And these patients, provided that they have a focal neurological deficit, these patients should be referred to the nearest HASU within 48 hours from onset, and the nearest A&E outside 48 hours from onset, according to the stroke pathway. And this is one of the examples. So this is a patient that I met a couple of months back in our TIA clinic with a progressive history of memory disturbance, a very young patient, very subtle signs. On the first encounter, we didn't actually find any neurological deficit, but the patient felt something wasn't right. And therefore, I trusted the patient, sent the patient to A&E, and this is what was shown on the scan, which confirmed the brain tumor. And the second case is a patient that I met on Friday last week in TIA clinic. It was actually my registrar who assessed the patient there, and patient had a memory disturbance with unsteadiness, so a bit vague about a week before for a few hours, completely resolved from that, and had another episode a couple of days back, only for a few minutes. And the patient says, resolved completely. Wife says, he's not right. Wife says, he's been forgetful, something's not right. There was no focal neurological deficit on examination, and the registrar called me asking what to do. Should I trust the patient? Should I trust the wife? And I said, you always trust the wife. So I sent the patient to A&E, and then this was actually what was shown in the MR. So the patient had multiple posterior circulation infarcts on the scan, and the patient actually did have some inpatient rehab needs. So now the patient's gone to our stroke rehabilitation unit instead of being discharged from A&E or from hyperacute stroke unit. So please do not consider these patients as a TIA. If there are any ongoing symptoms at all, please send them to the nearest hospital or A&E, depending on the onset time. So how to refer? MRI has an electronic system for GPs, I believe, and other hospitals have a referral form, which can slightly be different depending on the unit, which is slightly inconvenient. Please do not do letters. I'm not saying that this is wrong, but unfortunately, very often this results in significant delays, because what happens is if you write a letter, like a referral letter, very often that goes to, at least in Salford, I can say that for sure, that goes to neurology, and then neurology triage takes a few months, and then a neurologist who's triaging the referrals sends a referral back to us saying, well, this is for stroke team to triage, not even TIA clinic. And then it comes to our stroke triage in about a month, and then we see the referral saying, this should have gone to TIA clinic 6 months ago. So please try using the referral form. And I'll show you the Salford TIA referral form as an example. I know the majority of the referrals from GPs come using the referral forms. I do know that, but occasionally there are some referrals without using the referral form. So this is the current Salford referral form that has patient identifiers, whether any interpreters required, any clinical details and other symptoms that can be specified. It's really helpful when actually there are at least a couple of sentences stating what happened narrate, and whether the patient's been given aspirin 300 or not. If not, why not? If there was any contraindication or anything like that. And there is some safety netting about if the patient is taking anticoagulation, and then the patient should be having an urgent CT brain. And then there's a driving advice part as well, and there are risk factors. Really confusingly, there's ABCD2 risk score included in the referral form, as if you're expected to do this. But the referral pathway shouldn't depend on the ABCD2 risk score or any really any scoring system at all. So please do not use this. And we are developing a new referral form in Salford. Where to refer? So once you fill out the form, which is not necessary in Manchester Royal Infirmary because it's again an electronic referral system, and once you for other units, it's by email. So once you fill out the pro forma, they can be sent by email to these email addresses. Again, if they go to normal stroke referral emails, very often they are not triaged within 24 hours, which can then cause a significant delay. Right, so I'll move on to the driving advice after TIA. So I'm very sure you are well versed with this, and to be honest, it is our responsibility mainly when we make a formal diagnosis TIA, we should be giving the driving advice. But I know patients can be forgetful, or we sometimes forget to do it, and then you'll be asked these questions. So I hope this guidance helps. So this is the latest guideline. So when it comes to the Group 1 license, which is a car and motorcycle license, patients with TIA must not drive for a month, but they do not have to. They need not notify DVLA. If there are more than one TIA episode, they should be off driving for a month from the last episode of TIA, as opposed to previously there was for Crescendo TIA there was 3 months driving ban, but at the moment it's 1 month from the last episode. For Group 2 licensed drivers, they must not drive and they must notify DVLA, and they have a 1-year driving ban, and they wouldn't have any residual impairment, but they may require an exercise tolerance testing. There are some exceptions to driving advice. So there can be some transient neurologic episodes that are not TIAs. So once you refer these patients to TIA clinic, and we sometimes don't see these patients in the triage process, saying these are not TIA patients, or we see them and then conclude they're not TIAs. If they have amyloid spells, which is now called cerebral amyloangiopathy related transient focal neurological episodes, they have at least 6 months driving ban and they must notify DVLA. Again, as you can see, this is a specialist made diagnosis, really. Syncope, you must be more well versed than I am, and as you know, that the driving advice is completely variable depending on circumstances, cause, frequency, whether they were sad, whether they were stood, things like that, whether the cause was found, whether it was recurrent or not. When it comes to seizure, they have at least 6 months driving ban and they must notify DVLA. If they have carotid stenosis, even without TIA, the Group 1 licensed drivers wouldn't really have to notify DVLA, but Group 2 drivers should they should notify DVLA when it comes to significant stenosis, which is defined as more than 50% stenosis. This is a guidance on the GMNISDN website, which is really helpful, mainly for stroke patients. So most of these things are probably not applicable to patients with TIA. Any additional support for patients once TIA is diagnosed by a secondary care specialist? So again, it's our responsibility as well. But once they are discharged to community, they may come back to you asking these questions and asking for support. So provide all TIA patients who drive with the Stroke Association Driving and the DVLA leaflet, and advise patients to inform their insurance company. They obviously need the driving advice accordingly. And it's worth to note that Group 2 driving patients, they may wish to return to driving as a Group 1 driver and just give up on their Group 2 licenses. Then they can just contact DVLA and get their license changed to Group 1 driver license, unless there's any other restricting factors. These are some useful links which will be shared in the slides. Before I move on to the next part, should I get questions, or should I move on to the secondary prevention part, Chris and Asim?
I think you could move on, maybe?
Move on, yeah.
Yeah, I think a lot of questions are around the medications.
Yep.
So, as you saw earlier,
Yep.
and some more as well. So, do carry on.
Okay, lovely. So I'll talk about secondary prevention of TIA. Before I start, I want to say I could talk about this all day, all week. So I'll try to make this more relevant to primary care because there are so many rare causes of stroke. There are so many factors to consider. So let's focus on more important things, more relevant things, more common things. So I'll talk about antithrombotic treatment. I can see some questions in regards to that. Carotid revascularization, which may not be very relevant in primary care, but it's important to recognize if you think it is missed, the opportunity is missed in secondary care. Lipid lowering therapy, blood pressure lowering therapy, these things, you are experts in these, but I will talk about it from a TIA perspective. Oral contraception, hormone replacement therapy, obstructive sleep apnea, and lifestyle measures we'll talk about. So I'll start from antithrombotic treatment, including antiplatelet therapy and anticoagulation. So the majority of this is from National Clinical Guidelines from 2023. So it states, which is different from the 2016 guideline, dual antiplatelet therapy is provided therapy provided there is neither a contraindication nor a high risk of bleeding. And it can be one of aspirin plus clopidogrel or aspirin plus ticagrelor. There's nothing about, in this situation, you should choose this over that. There's nothing about that. So the first line treatment can be either aspirin plus clopidogrel or aspirin plus ticagrelor. The duration of dual antiplatelet therapy differs depending on the regimen. So for clopidogrel, it's 21 days followed by clopidogrel monotherapy. For ticagrelor, it's a month followed by ticagrelor monotherapy. And this is only after a formal diagnosis of TIA. So all these things are after a formal diagnosis of TIA, and therefore this is initiated by a specialist. And as you know, PPI should be considered for concurrent use with dual antiplatelet therapy. And if there are any other indications, they may have to carry on in a longer period. If dual antiplatelet therapy is not appropriate for some reason, for some contraindication, clopidogrel monotherapy is recommended. And then this is a new thing in the guideline. For patients with recurrent TIA or stroke whilst taking clopidogrel, consideration should be given to clopidogrel resistance, which can be tested by CYP2C19 genotyping. It's there are 4 pilot sites in the UK, 3 laboratory-based and 1 point-of-care testing-based, which is in Salford. It's a buccal swab test. We get the results in about 60 to 70 minutes, which is great. It doesn't matter whether the patient was previously on clopidogrel or not, because it's a genotyping test, not not a platelet reactivity test. Unfortunately, there's a funding issue, and this is not routinely available at the moment in primary care, at least, or even in secondary care. But it's worth noting that. And the other problem is that they are recommending us to consider clopidogrel resistance, but they're not actually giving any advice on any alternative medication. If patients are found to have clopidogrel resistance, they're not actually advising any alternative medication. If they're intolerant to clopidogrel, then aspirin 75 daily should be considered for long-term prevention. And as we all know, long-term dual antiplatelet therapy is not recommended unless there's another indication, such as stenting or anything like that. So we talked about antiplatelet therapy. Now we'll talk about anticoagulation. It's mostly patients with atrial fibrillation and flutter in TIA. As soon as intracranial bleeding has been excluded, provided there are no other contraindications, such as high blood pressure, which can be treated, and then anticoagulation can be initiated. Anticoagulation should be initiated. So it would be, the choice would be DOAC in non-valvular AF, and warfarin with low molecular weight heparin bridging for valvular AF with a target INR of 2 to 3. Should include measures to reduce bleeding risk using a validated tool. We use Orbit in Salford, and we compare that to CHATFAST score. Traditionally, in the past, HASBLES score was used. I'm not really sure what's in use in Stepping Hill, but they didn't actually specify which tool should be used in the guidelines. If anticoagulation is considered inappropriate, even though there's an indication, due to a high risk of bleeding, antiplatelets should not be used as an alternative when there are absolute contraindications. If there's no absolute contraindication, then antiplatelets may be considered. And obviously, we should reduce modifiable bleeding risk if they are modifiable. And you can consider a referral for left atrial appendage occlusion, again, which is normally done by secondary care clinicians. Carotid revascularization. So the assessment within 24 hours in the guideline includes carotid investigation as well. And in a form of normally carotid duplex ultrasound or CT angiogram or MR angiogram. So indirect imaging within 24 hours to see if there's any symptomatic carotid stenosis is recommended. And carotid endarterectomy should be performed as soon as possible and within 7 days of the symptom onset. If suitable for an open surgery, then stenting endoangioplasty should be considered. This is one of the reasons, not purely why, but one of the reasons why a prompt referral to TIA clinic is important. Now it's probably more relevant. Lipid-lowering therapy. I'm sure you know a lot better than any of us about lipid-lowering therapy. But it's worth to know that statins or lipid-lowering therapy should be offered unless contraindicated or investigation confirms no evidence of atherosclerosis. I'll talk about it later. And treatment should begin with a high-intensity statin, and they said such as atorvastatin 80 milligrams a day. They didn't say rosuvastatin, but as we all know, rosuvastatin is 20 or 40 is one of the high-intensity statins. Or it can be with an alternative statin at the maximum tolerated dose if high-intensity statin is unsuitable or not tolerated. Quite GMK record. And then there's more things about in the lipid management pathway rather than stroke guidelines, having a high threshold for recording a statin intolerance, given the benefits of statins. The target is fasting LDL less than 1.8 or non-fasting non-HDL less than 2.5. and it should be achieved at first review at 4 to 6 weeks. So they need rapid lipid lowering therapy rather than titration of statin treatment. And if the target is not achieved at first review, which is at 4 to 6 weeks, obviously adherence and tolerability should be discussed with the patient to make sure they're actually taking the medication. And if there's any room for increasing the dose, that should be considered. And ezetimibe, it should be considered as an addition. And then if applicable, injectables or bempedoic acid should be considered, along with a discussion around lifestyle measures. And this is, I included the link to the National Guidance for Lipid Management for Primary and Secondary Prevention of CVD. Again, this is probably very familiar for you. And then there's a GMMG approved lipid management pathway as well. And this is the secondary prevention bit of the national guideline, which you can have a look. Some special considerations. So if the patient is young, so below 60 years of age, and with a very high cholesterol, so total cholesterol above 7.5, or if they are, I think it was actually above, not below, if above 9, then they should, then a consideration for familial hypercholesterolemia should be given. And if they are below 60 years of age and there's a presumed atherosclerotic cause, lipoprotein A measurement should be considered. Now, the thing is, I'm not really sure if it's available in primary care, because about a month ago, I received, not personally, but then in my clinic, there was a patient who came with a letter from the GP saying, can you please do lipoprotein A? That was prompted by the GP, actually, thankfully, and I got it done on the same day. And obviously, especially if referral is needed, if raised. So even if you can't do it in the primary care, but I think you can prompt the secondary care clinicians, just like what happened a month ago to me. Now, importantly, if there's no evidence of atherosclerosis, especially as a cause of TIA, then for lipid-lowering therapy, primary prevention guidelines can be followed instead of secondary prevention guidelines. And this is part of the National Stroke Clinical Guidelines. And they can include dissections, moya-moya, thrombophilia, PFO, things like that. They are not traditional causes of TIA. And again, these should be clarified by a specialist. I'll talk about blood pressure now. So the target, very importantly, target systolic is 130 in clinic and GP surgeries and 125 at home, except for just one case, which is bilateral carotid artery stenosis, more than 50%, or it actually says severe, so severe would be more than 70%. And because of the risk of cerebral hyperperfusion, in that case, systolic target would be 140 to 150. And the choice of antihypertensives is pretty much the same in just normal hypertensive pathway. When? That was a question from Asim. When do we start blood pressure lowering medication? So it's prior to the transfer of care out of hospital if they're inpatients, or at 2 weeks, whichever is the soonest, or at the first clinic visit for people not admitted, meaning at the time of diagnosis of TIA would be the timing for TIA patients. So it would be from the secondary care clinicians, but we are sometimes not as comprehensive as you might think. So if you find any of those patients whose blood pressure is high, above the target range, please consider starting blood pressure lowering therapy as soon as possible. And how the target blood pressure should be achieved as how soon? It is as quickly and as safely as tolerated. So again, a quick titration is needed for the blood pressure lowering therapy. And obviously before any escalation of treatment, medication adherence should be checked. And once target blood pressure is achieved, an annual review should do the job. And the blood pressure monitoring should be guided by home blood pressure or ambulatory blood pressure for both compliance and control as well. And for home blood pressure, it's important to know there's a validated device, and it's important to educate the patient or the carers depending on the setting. And there's a list of validated devices in the British Irish Hypertension Society website. So once it's optimized, they should be reviewed at least once a year in primary care, and then their medication should be regularly reviewed at the same time as well. So now less exciting bit, oral contraception and hormone replacement therapy. Not a lot of evidence around this, but we know combined oral contraceptive pill should not be given to a patient who's with a diagnosis of TIA or stroke. And hormone replacement therapy, they should receive advice based on the overall balance of risk and benefit, but it should not be used for secondary vascular prevention, and we advise referring these patients to secondary care for specialist advice. Very important bit, OSA. There's a very high prevalence of OSA in patients with stroke, and it's an independent risk factor for stroke and TIA because of a lot of impact on cardiovascular health. So any patients with a history of TIA should be screened for OSA with a valid clinical screening tool. In the stroke clinical guidelines, they didn't specify which tool, but in the NICE CKS, they recommended stop bang and Epworth sleepiness scale. And if screen is positive, they can be referred for specialist respiratory or sleep medicine assessment. And this is a copy of a stop bang questionnaire. It takes about a minute to complete. It's very straightforward, and I found it very, very easy, very, very easy to complete it. And I referred a few patients in to respiratory as a result. Lifestyle measures, when it comes to physical activity, we are often asked by patients about this. I'm sure you are as well, but there's not really any specific target. So that this should be individualized, but they should really aim to be active every day and not so sedentary. If they are at risk of falls, they need additional physical activity to improve balance and coordination at least twice per week. There's a new bit about cardiorespiratory training, but it's probably more relevant to community therapy team and fitness instructors rather than GPs. And there's a stroke association information for patients, which is very, very helpful. When it comes to smoking, they should be advised to stop immediately with an individualized prevention plan. Nutrition, it's pretty much the same as anything else. It's not very different from the advice for primary prevention. So five a day, fish, less saturated fats, more unsaturated fats, things like that. It's worth noting that there's no target weight loss for prevention of TIA or stroke, and there's no routine supplement intake that's advised for prevention of TIA or stroke. That's it from me.
Thanks, Jay. That was a really great talk, and there has been lots of questions, so I thought it might be useful to go through it step by step just to make sure that I don't forget any. There's a lot around the initial approach, aspirin or clopidogrel or DAPT, when you first suspect a TIA. And specifically, there was a question if someone is already on a DOAC, and I think you've discussed that in terms of the scanning and the suspected TIA. And then there's another question of what if they're already on aspirin or clopidogrel, and what do we give them while they're waiting to see the TIA clinic as well, in terms of loading dose or continual?
So a loading dose would be in a patient who's not already on those antithrombotic medication to achieve the level, the blood level as soon as possible. So if they're already on some sort of antiplatelets, I would generally advise them to continue. But if it's aspirin 75, then I normally it's a tricky one, to be honest, because it's actually nowhere in the guideline, because guidelines are assuming that these patients will be reviewed in 24 hours. That's the problem. And GMNISDN website says they should be given aspirin 300 until they are seen in the specialist service. But that can mean aspirin 300 forever. Aspirin 300 for a month or 2 months. So that's actually a difficult question to politically correctly answer. What do you think, Krish?
I think I would support aspirin 300, primarily because majority of the patients are on if somebody's on antiplatelets, maintenance is very likely to be clopey. And with the knowledge we have around resistance, so obviously they had an event on clopey. And with the data coming through with regards to clopidogrel resistance, my preferred approach would be to go on aspirin 300. Obviously, you need to consider PPI cover pending their review in the thing, but no more than 14 days. I see.
Okay. And we can make sure that we put that in our toolkit for primary care clinicians as well.
Yeah.
So aspirin 300 is preferable, and if, I guess from the GP side, if they're already on anticoagulation, then it's more hospital acute, and therefore there's this uncertainty left really just while we're waiting. And I think something I've learned from you, speaking to you both, that I think it's might just worth reflecting is that the risk of a repeat is highest immediately. Is that right, Shir? So in that immediate time.
Yeah, the risk is front-loaded, even though it says the risk of a subsequent stroke or TI is highest in the first 90 days. Most of that risk is front-loaded in the first 7 days or even 48 hours.
Yeah.
So it's definitely doing what I said before is useful. And there was another question around DOAC, but came to the attention of the GP a week later. What would you do? My advice would be still referring for a CT. Because they might have had an incident small bleed, they could have another one. So I don't think the time matters. If they had an event within a week, you would still refer.
Yeah, thanks. And thanks for raising that, Shiv. I think it was something that we have discussed when writing that toolkit, and especially understand the realities and practicalities, which I think is what the questions are about. But it was a big learning point for me, and I'm sure others as well, to take it seriously and consider, even in people who don't have symptoms currently, but who might be at high risk of bleeding as well.
I think Asim, sorry to interrupt, just on the antiplatelet, just one point I want to reiterate. I think Jay has said that already, is we don't currently recommend DAPT at the point of primary care suspected TIA. I think that question kept asking David. There was a wide debate around it. We don't even recommend that at the ED level because the TIA is such a broad spectrum. It is the DAPT is reserved at the point of diagnostic confirmation. Let us put it that way, rather than because of the risk benefits and more data is coming around ticagrelor, whether it is really useful or not. So yeah, so I think just want to clear that on that. Thanks.
And so people I think this is a key point in this. So I think it's just worth us making sure that everybody is fully clear on it. Yeah. And if someone is already anticoagulated, you wouldn't give them aspirin anyway. It's scanning for bleed. Yeah. Is there anybody on the call who's not clear about this? Because it's an important point, and maybe we need to do more to make it clearer for everybody as well. Okay, I think the vast majority of questions were around around the antiplatelet. The other thing was about the blood pressure thresholds, and they are lower in people post-stroke. But is that something that you would want us to do, or would want us to kind of wait for an indication from the TIA clinic? Or...
It would be after the confirmation of TIA diagnosis, I would like to say.
Yeah. Okay. And Dixon's just clarifying if already on. I think we do. We probably need a page that makes this more clearer because of the uncertainties around. So if they're already on it, you're suggesting to give them aspirin 300 until they're seen.
Yes.
Yeah.
Replace.
Yeah. Okay. And that, for clarity, is because they may not be seen the next day, which is implied by the NICE guideline and the statement on NICE. Is everybody clear on that? No more questions or comments. So I think that is now clear to everybody. And Chris, I think you've brought up a slide here as well.
Yeah, there's just one question pops up there, I see. I don't know if you just caught it at the end in the chat.
Yeah, so Jay and Krish, these are the realities. I suppose Krish is quite clear earlier when he was saying about aspirin for 2 weeks at 300 at the most, and then supposing at the moment I would interpret that as being dropping back down to 75 while awaiting clinic. I think the uncertainty means that our uncertainty is at the beginning. If they're on aspirin for 2 weeks, that uncertainty will be less, or they may have another event by then as well. Okay, I think we will. The TIA toolkit we've drafted it, it's almost done, but I think we will update it just to make these things a bit clearer. It will be linked to in EMIS in the F12 GM CVD guidelines launcher. If you haven't already seen it, all of our guidelines, including lipids, blood pressure, and anything else, is all easily accessible there. The web page is going to be really good, and the one place that will be kept up to date with all the details of the clinics and numbers at any time. So if you ever need to do that referral, that there is now a place where you can go to quickly get the form or the contact to the email as well. Right. I hope it's been a good session for everyone. I just wanted to thank Chris, Jay, and Chris and the network for setting it up. I know how difficult this can be, and I hope it's been useful.
It's great. Thank you, Asim, for your involvement as well. In terms of our evaluation, it would only take a couple of minutes. We'd be really keen for you to give us both positive and negative feedback. Obviously, we'd like to make this better for you in the future, and if it's needed, a regular occurrence. So please feel free to scan the QR code with your phones, and it'll take you direct to a link that hopefully you can just spend a couple of minutes and give us some valuable feedback. And finally, just want to say thank you on behalf of our patients. You're all here for our patients at the end of the day. So thank you very much for your involvement and engagement.
Thank you. Thank you, Chris.
Take care, everyone.
Thank you.